Hi, my name is Bruce Strober. I'm professor and chair at the University of Connecticut Health Center, Department of Dermatology. And I'm here to discuss the paper describing a comparison between brodalumab, an IL-17 receptor blocker, and ustekinumab, a well-established IL-12/23 inhibitor that's been on the market for 7 years. This was a study published in the New England Journal of Medicine in 2015, October. And it's really a compilation of two different studies done independently, yet having the same study design. In essence, brodalumab examined at two different doses, 210 milligrams and 140 milligrams, given every 2 weeks as a subcutaneous injection, was compared to ustekinumab, given as a standard dose as per its label. In other words, 90 milligrams for patients greater than 100 kilograms and 45 milligrams for all other patients less than that amount of body weight. So standard dosing, double-blind, assessor-blind, very fair, reasonable data that you can believe in a clinical trial setting. Every patient had to have moderate to severe psoriasis. There actually was a placebo group in this study, which kept the patients and the assessors honest, so to speak. And essentially, it showed that at the 210 milligram dose of brodalumab, that you saw superiority of efficacy of that drug compared to ustekinumab, and of course, compared to placebo at 12 weeks. In other words, patients achieved better response rates. There were a higher number of patients who achieved a PASI 75 who got the higher dose brodalumab, 210 milligrams, than patients getting ustekinumab, who achieved a PASI 75. The number comparison was about 87% versus 69%, brodalumab versus ustekinumab comparatively. Importantly, this study actually examined PASI 100 achievement rates, full clearance of skin. And that really is, in my opinion, the more important point, that brodalumab and other IL-17 inhibitors achieve PASI 100 clearance much more likely than older biologic therapies and certainly older conventional therapies. Basically, 40% of patients getting brodalumab versus 20% getting ustekinumab achieve PASI 100. So in that regard, patients are twice as likely in all reasonable estimations to achieve full clearance on brodalumab 210 milligrams, which is likely to be the approved dose. So this follows on other studies of IL-17 inhibitors. There are two other IL-17 inhibitors, ixekizumab and secukinumab, which both also show higher efficacy than ustekinumab and other biologic therapies, either in head-to-head studies or in their independent analyses done in phase 3. So IL-17 inhibition is a superior approach to clearing patients with psoriasis. There's no doubt about it at the doses we can use of those drugs. It should be noted, though, that secukinumab and ixekizumab are both approved drugs for the treatment of moderate to severe psoriasis, and they work slightly differently than brodalumab. They block IL-17 directly, whereas brodalumab blocks the receptor for IL-17. So slightly different MOA, yet we're seeing no matter how you do it, you get high levels of clearance. Now, the issue, of course, comes down to safety. Ustekinumab, a drug we're using, like I said, for many years, is clearly a very safe medication, and it's very well tolerated and has an advantage of being infrequently dosed. As you likely know, it's dosed at week 0 and then 1 month later, and then every 3 months thereafter. Very infrequent dosing. And the IL-17 drugs will be self-injected and dosed more frequently to a variety of dosing regimens. But in general, it's going to be every 2 weeks or every month, depending on drug and where you are during the course of therapy. So more frequent injections for the IL-17 blockers. The other key differences are perhaps tolerability and side effects. Ustekinumab, like I said, very clean drug, maybe slightly increased risk for upper respiratory tract infections, but mostly patients don't have infections, don't have malignancies, don't have nuisance side effects, intolerability issues, or painful injections for that matter. Whereas the IL-17 blockers have one very common side effect, which is oral candidiasis, mucosal candidiasis, mostly mild in nature. Most patients can be treated right through it with appropriate therapies. That said, it is an issue you need to look out for, probably in about 5% of patients, roughly speaking, for any of the IL-17 blockers. And brodalumab was not unique in that regard. The other issue that is hanging over the head, quote unquote, of brodalumab, not ixekizumab and secukinumab, is a really ill-defined risk for suicidal ideation and suicidal attempts. There were noted 6 suicides in the entire program for brodalumab, with the denominator being 6,000 plus patients. So 1 in 1,000 risk in all of the brodalumab studies of suicide. Now, the FDA weighed in on this, and clearly they and nobody else really has a firm grasp of the true relatedness of suicidality, suicidal behavior to this drug. And in the end, we're going to have to wait for post-marketing surveillance studies to either refute or establish the risk is real. So it's left to be seen how the regulatory authorities, both in the US and overseas, weigh in on suicidality and brodalumab. It is clear to me they're not going to create the issue for ixekizumab and secukinumab, which don't appear to have this signal in their clinical trials program. Now, the other issue I should mention is a rare risk of inflammatory bowel disease, onset or exacerbation in people getting IL-17 blockers. Again, it's a very infrequent finding, probably less than 1 in 1,000 in patients in the studies for all 3 IL-17 inhibitors. Though it is clear if a person has a pre-existing history of inflammatory bowel disease, Crohn's disease or ulcerative colitis, that we need to be careful and probably lower those drugs and IL-17 inhibition drugs down the treatment hierarchy. Probably use TNF inhibitors and ustekinumab before those drugs. It should be noted that IL-12/23 inhibition probably treats inflammatory bowel disease, and there's probably a forthcoming approval for ustekinumab in the treatment of Crohn's disease within the next 6 to 12 months. So completely opposite story for IL-12/23 inhibition. And finally, we don't know how IL-17 inhibitors will treat psoriatic arthritis or systemic inflammation more broadly. There are good data though, showing that secukinumab and ixekizumab treat psoriatic arthritis signs and symptoms and inhibit joint destruction. So a high level of confidence is building that IL-17 inhibition would be a good approach to psoriatic arthritis. In fact, secukinumab already has FDA approval for that disease state. And I'm guessing down the line, the other IL-17 blockers will too. So we are seeing advantages with the IL-17 inhibitors with regard to efficacy, no doubt about it. They are more efficacious than the previous biologics, be they IL-12/23 inhibitors or TNF blockers. We are not going to say now that they're safer. They have unique safety issues, which seem, for the most part, rare and manageable. And I'm comfortably using IL-17 inhibitors in my clinic. I think they have the makeup of first-line drugs. And finally, the issue of cost and access will remain as a prevalent concept in all treatment scenarios. So whether or not you choose IL-17 inhibition as first, second, or third line for your patients, I would say you're always on firm footing. I have high confidence these drugs are here to stay and will be more and more integrated into how we treat moderate to severe psoriasis.